rheumatic fever is a traditional favorite. It usually shows up in some way on your Step 1 exam. There are so many aspects to the pathophysiology of this disease, including immunology and microbiology. Now, test question writers can confuse you with some of the other diseases that present in similar ways, especially in the pediatric population. What are we talking about? Definitely talking about Kawasaki, right? So, what are some things that you need to worry about as opposed to rheumatic fever and Kawasaki disease? Remember, they have that desquamative rash, and by desquamation, it means that the actual palms and soles are involved. So the rash is usually mucocutaneous, and it definitely has to involve desquamation of the palms, definitely the soles. So those are key to be able to say that someone has Kawasaki disease. In addition to that, there's cervical lymphadenopathy, so LAD. That's a great way to abbreviate that. And then, of course, another extension of that mucocutaneous involvement is classically they'll have a strawberry-looking tongue. So before we even start, let's make sure we have that in our mind. Kawasaki disease is a classic way for you to get confused. A lot of different presentations when it comes to rash in the pediatric population as well. So, one more thing. We need to understand that there's a difference between scarlet fever and rheumatic fever. So, if we put rheumatic fever here on the patient's left and scarlet fever here on the patient's right, we can kind of go through them and discuss them. So scarlet fever is named exactly so because many patients literally turn scarlet colored. So scarlet is kind of like the color of that pen ink, really red, right? And this is kind of like a hypersensitivity reaction to an erythrogenic toxin from the group A Streptococcus species. Now, since it's a hypersensitivity-like reaction, that means that a kid had to be infected once for the initial exposure to this antigen or toxin, and then they are infected again, and the immune system reacts to seeing that same toxin again. Again, that is the fundamental pathophysiology behind scarlet fever. Now, scarlet fever usually first shows itself in a kid with, again, here's another situation where we have a strawberry tongue. Well, we just had that in Kawasaki disease, so that can be a great way for test examiners to confuse you. The thing about the scarlet fever is that they have a scarlet-colored sandpaper, and that is a particularly unique description of a rash. When you hear it, that should make you think about scarlet fever. So they have a sandpaper-like rash, and it is very unique in the sense that the rash will also desquamate, and we keep on using that word, so let's write it out. So there's desquamation, so we lose our epithelial component of the epidermis because there's a hypersensitivity-like reaction that causes cleavage of the connections between the cells of the epidermis. Now, what is important to understand is that this desquamation here that we just talked about, it does not involve the palms, and it does not involve the soles of the feet. So that helps us differentiate between Kawasaki disease. Kawasaki disease usually has a desquamative rash that involves the palms and soles, while scarlet fever has a sandpaper-like rash that will eventually desquamate. It does not involve the palms or the soles. Now, acute rheumatic fever. So acute means that it happens very quickly and in a short time frame. Acute rheumatic fever is a very different beast than scarlet fever. Pathophysiology is different. Acute rheumatic fever is also a consequence of this group A strep, so they share this component together. It is a reaction by the immune system towards group A strep antigens, except that instead of a hypersensitivity-like reaction, this is antibody-mediated. So this is an antibody component, and that means that we have a little bit of a time lag, and that's why it usually takes 4 weeks for this to present. The whole thing is this concept of molecular mimicry that occurs due to antibodies being generated against cardiac antigens that were exposed to the immune system. So, what does acute rheumatic fever classically present like? Well, we have a criteria called the Jones criteria, and this is a component of arthritis, carditis, chorea, subcutaneous nodules, and erythema marginatum. Now, a great way to think about this is to actually think about the bacteria. So let's think about Streptococcus pyogenes. Sorry for the handwriting. I do not have my stylus with me, so I hope that you guys are okay with this. Now, what do we know about the Streptococcus pyogenes? It's a group A strep, and we know they have a bunch of scary virulence factors that contribute to the pathogenesis and presentation that you would see with this disease. Now, for example, Streptococcus pyogenes also has a toxin called streptolysin. Now, what can I tell you about streptolysin? Well, you probably already know a lot about it, but let's review. It's an exotoxin that binds to cholesterol. Where's cholesterol found? In the plasma membrane of a lot of cells, right? And it's particularly targeting red blood cells, neutrophils, and platelets. So let's think about what would happen if we had a toxin against the cholesterol component of our plasma membrane. We'd probably lose some of the integrity of our membrane, and that's exactly what streptolysin does. It allows water to enter and lyse, so you get lysis of all of these cells. Hence the name streptolysin. It comes from streptococcus, and it causes lysis of red blood cells, neutrophils, and platelets. The reason it does that is because it disrupts the cholesterol component of the plasma membrane and allows water to enter the cells. Hence the name streptolysin. Now, our body produces antibodies to this protein, and we look for them to help detect the presence of this disease in our patient population. Now, what are these antibodies called? These antibodies are called anti-streptolysin O. So we're looking for antibodies that were generated against the toxin that was initially causating that cell lysis of neutrophils, red blood cells, and platelets. What other virulence factors do we need to be concerned about when we're talking about Streptococcus pyogenes? There's another enzyme called streptokinase, which helps activate plasminogen, which is a zymogen element or component that eventually is cleaved by streptokinase into plasmin, right? The streptokinase is generated by group A strep, Streptococcus pyogenes. It also has one that we've heard and talked about before, which is hyaluronidase, right? And hyaluronidase cleaves hyaluronic acid that is present on a lot of important areas of connective tissue, particularly with the heart. Now, this is a great time to flash back to your immunology. What is the protein present in group A Streptococcus pyogenes that our immune system will produce antibodies to that cross-reacts with heart antigens? You say, I don't know the answer. Well, it's the or M protein, right? The way that the pathophysiology works is all around this molecular mimicry. The problem is that this protein shares epitopes, right? That's an immunology word. They'd love to ask you that one, wouldn't they? Love to toss this into the question somehow. The problem that the M protein does is that it shares epitopes with another important structure that we need in our heart, and that is myosin. And that is why this was initially called the M protein. So a lot of ways to remember this. Molecular mimicry with the myosin component. Obviously, this leads to a myocarditis. So M is a great way to remember this. Molecular mimicry to myosin by the M protein. Our immune system will cross-react with our myosin because it wants to target the M protein, which is a component of the Streptococcus pyogenes species. And then we get a myocarditis. The antibodies produced against the M protein cross-react due to molecular mimicry. Myosin is in the heart, M protein targets it. That's a huge, super high-yield baseline fact that you have to have in your head. Now, what's interesting is that there's another molecular mimicry antibody that can also cause problems. This is due to creating antibodies against another polysaccharide component of a group A strep. Whenever you create antibodies to polysaccharides of the bacteria themselves, you can get a cross-reaction to the glycosaminoglycans, or GAGs, that are present in many areas of the heart, particularly on the heart valves, because they want to be very loose, fluid-rich tissue, and that is what actually glycosaminoglycans do. They're very electronegative structures that pull in water, and these are present in our connective tissues. So if we start making antibodies to this guy, and it's present on our heart valves and other areas, that's going to be a really bad situation, right? So anytime you have any suspicion of someone having acute rheumatic fever, you need to go ahead and treat it, because it's a really bad thing to make antibodies that can bind myosin of cardiac tissue and glycosaminoglycans that are on things like the heart valves, correct? Yes? Now, this is why streptococcal pharyngitis is kind of a big deal. You should give them penicillin anytime you suspect streptococcal pharyngitis. Now, what else are we talking about when we talk about this molecular mimicry? Well, some of the other antigens of Streptococcus species can have similar epitopes with gangliosides that are present in the brain. So now we're in even more trouble. We have the component of molecular mimicry with the M protein to myosin, with glycosaminoglycans to a particularly polysaccharide-rich segment of the Streptococcus species. And then we also have this molecular mimicry component to gangliosides. Now, where would you find gangliosides in our brain? Now, what kind of symptoms do you think will be present if we were generating and depositing antibodies in our brain in somewhere that is a very high-rich ganglioside concentration? Now, gangliosides are components that surround nerves, right? Part of the myelin sheath, right? So think about someone that's highly myelinated in the brain, someone that needs a great conductive ability, fast conduction, because big, fat, or really myelinated axons conduct very fast. I'm talking about the place such as the basal ganglia. Now, what kind of symptoms are you going to get when you get antibody deposition and an inflammatory response in this area of the brain? You will have chorea, right? Perfect, makes sense, right? So chorea is just Greek for dancing. Someone with chorea looks like they have uncontrolled dancing movements because there are antibodies binding to the ganglioside components within the basal ganglia, which means that they are triggering a signal that results in undesired movement. So let's discuss rheumatic fever using our immunology thinking hats. So, someone has group A strep. The tonsils are infected. Antigens of the bacteria are taken up and processed by antigen-presenting cells. Antigen-presenting cells activate CD4 T cells to become helper 2 T cells, induce the activation of B cells to be specific for a certain type of antibody response, and then they differentiate into a plasma cell population that will just start cranking out antibodies like it's their job. Wait a second, that is their job. Now, eventually, this deposition of these antibodies due to molecular mimicry causes activation of the complement system on wherever you deposit it. So we deposit it again on the heart valves due to the molecular mimicry with the glycosaminoglycans, on the myosin component of the myocardium causing our myocarditis, and again, on gangliosides in the basal ganglia. That's pretty easy to remember. Ganglioside, ganglia, molecular mimicry, causing chorea, or uncontrolled dancing movements. Now, what's important for us to understand is how the rheumatic fever can lead to sequelae over time. So if you have chronic activation and inflammation on your heart valves, this leads to, obviously, fibrosis and thickening of your heart valves. So if you imagine a heart valve, and you always put antibodies on it, eventually you're going to have a fibrotic response because that is how the heart heals. Now, you must understand that there is a 10 to 20 year difference, right? Acute rheumatic fever and then having the sequelae such as a fibrotic heart valve is a 10 to 20 year gap. It's not just going to happen immediately. So let's talk a little more about this. The acute phase of rheumatic fever usually presents 10 days to 6 weeks after the initial infection. It is super important to know that pharyngeal swabs for the group A strep in the throat will be negative by the time you hit this window of acute rheumatic fever, 10 days to 6 weeks. Your patient will most likely be under the age of 15 in your vignette, and in order to diagnose someone with rheumatic fever, you must fulfill those Jones criteria, right? And this is the way I like to write the Jones criteria. The Jones criteria includes a migratory polyarticular arthritis, and you can remember that because of joints. And it's migratory because it shifts from joint to joint. Polyarticular. Articular means where the articular surfaces of the joints, so this means that it involves multiple joints because poly is many, and it's an arthritic-like component, so there is inflammation of the joint. You get the carditis, which I remember with this little drawing, which is the myocarditis component, again from the molecular mimicry of M protein towards the myosin element of our sarcomeres. We get subcutaneous nodules, and I like to think about that as inflammation from the antibodies depositing in the papillary dermis. Whether this is the actual case or not, I'm not 100% sure, but that is the way I like to think about it in my mind, and it helps me remember how it's antibody mediated and with generation of nodules. Now for the E, that's our erythema marginatum, which is also another skin component of this disease. And it is named so because the margins of these lesions are very erythematous, right? There's a high color difference between the red border and the central, usually clear area of the lesion. And again, this is also easier to remember because it can also be caused by a response to an erythrogenic toxin that's also produced by group-A strep. The rest of the signs and symptoms are easily remembered if you think about how we just turned on our immune system against ourselves due to this molecular mimicry that happens in immunology. So anytime you activate your immune system, you're obviously going to have fever and an elevated ESR. Due to the production of antibodies and inflammatory proteins, you'll also have high levels of fibrinogen and CRP, C-reactive protein. So one of the things that we hear a lot is this ESR. It's important to understand what it actually means. Let's quickly illustrate what we're talking about. So to measure the ESR, now it's all standardized and there's a machine, but let's say we're back in the old days and we're actually in the lab doing this. So an elevated sedimentation rate means that there's an increase in the rate that things are sedimenting, right? So let's quickly draw what we're even talking about. So that our red blood cells in this test tube, and these are all red blood cells. We just said that when we activate our inflammatory response, we generate a bunch of proteins such as fibrinogen and CRP. There's a lot of acute phase reactants that are generated. Where are they going to go? They're going to go in the blood, and they're also going to interact with these red blood cells. So while some red blood cells, if you were to take this, would be able to sediment to the bottom, usually red blood cells repel each other, right? That makes sense. You don't want red blood cells sticking to each other. They usually have charges that cause them to stay away from each other. And it takes a long time for erythrocytes to settle towards the bottom because normally they repel each other due to the electronegative charge they have. So usually red blood cells take a pretty good amount of time to settle at the bottom or sediment, right? This is great because we usually don't want red blood cells to stick to each other, so think about it in that way. Now, if we have a bunch of inflammation and there's fibrinogen around, think about fibrinogen sticking and covering and coating these red blood cells. What is that going to do? That's going to create a little bit of a problem because we kind of cover up some of the electronegative charge that allows red blood cells to repel each other, and you're coating each red blood cell with sticky fibrinogen. And now these red blood cells are going to stack against each other, and they're going to make a formation called a rouleau formation. You usually classically hear this with multiple myeloma, but a rouleau formation can actually happen in any situation in which you disrupt the normal repulsive forces between red blood cells. So again, in the situation of any type of inflammation, you can have acute phase reactants generated. One of those is definitely going to be fibrinogen. Fibrinogen can stick to the outside of red blood cells and eliminate electronegative repulsive forces, causing a rouleau-like formation that looks like a bunch of poker chips. Now, obviously this is able to sediment at a much faster rate than individual red blood cells. Obviously, yes? Great. That's why you have an increase in your erythrocyte sedimentation rate. So, now, it's great that we visualize that. You have an increased erythrocyte sedimentation rate because of the rouleau formation. You lose the normally repulsive forces between red blood cells. They have no reason not to sediment at the bottom of the test tube really fast. And that is why your rate or velocity of this happening is increased. Now, how that works is important, but we need to get back to rheumatic fever. The deposition of these molecular mimicry capable antibodies in the skin is what causes the subcutaneous nodules. The deposition of antibodies into the synovial membranes of our joints causes arthritis that moves from joint to joint, which is migratory, polyarthritis. Now, even though if we know all this Jones criteria, we know the difference between acute and then a later presentation and scarlet fever, we still need to know some imaging and histology, because that is a great way for them to ask you about this disease. We need to be able to understand and recognize what we see on microscopy and then relate it back to the pathophysiology we just discussed. Oh, okay, great, cool, easy? No, this is a hard thing to do. Now, when you look at this slide, it just looks all the same, doesn't it? What are we looking at? These are Aschoff bodies. These are granulomatous, so it's like a granuloma, like you would see in any other type of disease where you have a granuloma, non-caseating. And these granulomatous nodules are within the heart. They're composed of T cells, T and B cells, so lymphocytes, plasma cells, and a bunch of abnormal macrophages called NHCal cells. So these are abnormal macrophages that you would see within an Aschoff body. Let's look at these cells a little bit closer. The NHCal cells are macrophages that have highly condensed chromatin within them. As you can see, these kind of look like little caterpillars, right? So these abnormal NHCal cells are just abnormal macrophages with highly condensed chromatin in a linear fashion that makes them look like caterpillars. Sometimes these are called caterpillar cells. When these abnormal macrophages with condensed chromatin fuse together, then you call them Aschoff cells. So if you take a bunch of these caterpillar cells, which are NHCal cells, and put them all together, because that's what macrophages do when there's a bunch of inflammation for a long period of time, you can have fusion forming giant cells. In this situation, when these caterpillar cells or NHCal cells fuse, they become very dense-looking Aschoff cells. So it's confusing, but it's important to note that NHCal cells become Aschoff cells, and an area that is including T and B lymphocytes, plasma cells, in addition to the NHCal cells and Aschoff cells, is called an Aschoff body. Excellent. Let's continue and move on to another high-yield subject for you guys.